this week on the BackTable podcast.
I would say the biggest thing is just to have that suspicion. And it's the same thing across all these different more rare conditions is just have the suspicion that, there could be something more to it. Not every globus, not every mucus sensation is reflux. Not every person with some dyspnea is paradoxical vocal full motion. That there's always this kind of, just to have that suspicion that these are rare conditions, but certainly at least be aware that there's a possibility and be ready to look a little further if you need to.
Hi, everybody. Welcome to the BackTable ENT podcast. We're a podcast that focuses on all things otolaryngology, and we've got a really great show for you today. Thanks for stopping by. We got a great show today. I'll be one of your hosts, Ashley Agan, joined by the lovely Gopi Shah. Good morning, Gopi.
Good morning. How are you, Ash?
I'm doing great. How are you?
I'm doing good. I'm really excited because we have an awesome guest on today. We have Dr. Stephen Schoeff. He's a laryngologist practicing at Kaiser Permanente in Washington. He's here today to talk to us about idiopathic subglottic stenosis in adults. Welcome to the show, Steve. How are you?
I'm great, thanks.
First, we like to set up the show just giving you a chance to tell us about yourself, your journey, your practice. How'd you get here?
Yeah, so I started out in Ohio. I went to Ohio State undergrad, grew up close to there, and then went to University of Virginia for medical school and residency, where I did a otolaryngology residency there, and then worked with Jim Dinero there, who is a great mentor for laryngology and helped really start my interest, particularly in idiopathic subglottic stenosis. And then went on to do fellowship at University of Wisconsin with Dr. Seth Daly and Dr. Francis. And then from there, joined Kaiser Permanente in Washington to kind of build a laryngology practice there in what is otherwise largely a general practice, kind of comprehensive otolaryngology setup. So kind of adding a lot of office procedures and a little bit more comprehensive management for voice, airway, and swallowing for our patients.
So just before we get into the discussion, I do want to give a couple of shout outs to Dr. Jim Dinero. We were residents together at Jefferson. So it's really awesome that you got to work with him. He's wonderful. So we'll have to get him on the show at some point. I was just recently in touch with him. And then Dr. Seth Daly also was on BackTable, one of the earlier episodes on why to join societies, and he was super cool. It's something I encourage everybody to check out. And of course, we have to give a shout out to Ali. So Dr. Behati, Ali Behati is Dr. Steve Schoeff's wife, your wife, who's one of our main hosts on the BackTable IR Vascular and Interventional show. So it's really cool to finally have you on, Steve. I feel like it's been a long time coming, so we're super excited. All right, so we're talking about idiopathic subglottic stenosis in adults. Tell us, how do these patients usually present to you? Is this a patient that's just going to come to you randomly in clinic, or are you seeing these patients in the hospital or in the ER?
That's a great question. And, at some level, it's an all the above sort of answer. But, idiopathic patients really do tend to present a little differently than some of the other causes of subglottic stenosis. So the classic kind of subglottic stenosis that most non-laryngologists think about is going to be more of your traumatic or iatrogenic subglottic stenosis. And you're likely to encounter that patient in the hospital. They've been intubated for a while, or they've had a tracheostomy and then they have an A-frame deformity. And a lot of times they're going to be in these kind of higher acuity settings and a more rapid onset of symptoms or sort of persistence of symptoms. Whereas the idiopathic patients tend to get shuffled around quite a bit. They often are kind of otherwise pretty healthy. They're showing up with some mild stridor potentially, but often not even stridor at their first presentation to someone, where they're presenting, say, to their primary care provider with increasing mucus in the throat, which we all know is a super common complaint, or kind of increased cough, maybe slightly shorter breath, but pretty gradual, pretty slow onset. And that's part of what makes this such a challenging condition, is that they oftentimes get managed with some OTC meds or maybe acid reflux meds and albuterol inhaler, and they're not getting better. And oftentimes we'll end up kind of actually getting sent over to allergy or pulmonology first. And then finally, the stridor becomes more noticeable. And that's oftentimes when they may either end up in a urgent care or emergency room setting or in the ENT clinic.
Do most of your patients already have the diagnosis by the time they get to you?
Yeah, I would say a good portion come to me with a diagnosis. So either they've been into an urgent care, an emergency room, and are getting a scan, a CAT scan that might show it, or they're being seen by an ENT consultant, or getting into a general ENT clinic where a careful flexible laryngoscopy exam might show it. But it's also quite possible for these patients to get into an ENT clinic and say just kind of a standard flexible laryngoscopy. It might not be evident. And if the stridor isn't particularly noticeable, it can even be missed in that setting as well. So I would say the majority of patients have at some point gotten a diagnosis before they end up in my clinic, probably about, I'd say 85 or 90%. But occasionally I do get patients where they've had stridor, they've had dyspnea for a while and end up in my clinic and we're finding it for the first time.
Are these patients usually younger or older? Like I think of, in peds, we have subglottic stenosis. You think about the NICU baby or child that's been intubated, right? Same risk factors you think of in majority of your adult patients, I would imagine. So when I think of congenital, it's such a small, like in a child or an infant, I think it's such a small percentage. Are these kids, do they have a history or are these patients younger or older when they present and have they had history of like, oh, I had a ton of croup when I was little, anything like that in terms of risk factors?
Yeah, it's a great question. Usually they don't have anything remarkable in their history. And sort of by definition, we're saying that they haven't had any prolonged intubation or anything of that sort in the time frame before the symptoms started. But they, and interestingly, I've had patients, I've seen patients present sort of de novo all the way from the early 20s to late 70s. That they're kind of presenting for the first time. So I'm managing a patient who I think we started treating her at 77 or 78 years old.
Wow. That's a huge age range. And what about male versus female?
So that's another great question with this is considered really a female disease in terms of a dramatic female predominance. In some will argue that it can only occur in females. However, I have a patient I'm taking care of who is male who presented with several years of gradual dyspnea and no intubation history and had a very classic appearance of subglottic stenosis. Fortunately for him, the male anatomy, the male airway just tends to be larger. So it takes longer for it to really close off in the way that really restricts somebody so that they're kind of avoiding a crisis, so to speak. But I would say, it has somewhere 97 to 99% female predominance.
Okay. So no particular age is classic, but definitely female presenting with maybe a worsening shortness of breath, eventually stridor, and maybe some other non-specific ENT symptoms.
And some mucus.
And mucus.
And mucus.
Throw on some mucus.
Mucus is really a hallmark of this, which is really interesting as well. That's kind of, once you get somebody's airway open, that's the thing that they notice the most. I would say that there's probably a bell curve in there. So I would say, most patients are probably presenting more between, as you go to 30 to 70, 40 to 60, you're probably getting a higher concentration there in that range, that age range.
Let's kind of think about the patient that hasn't been diagnosed yet. When you're going through your history taking, are there particular questions that you're asking to kind of screen for this diagnosis in particular that's unique, or is it kind of, your standard list of questions from your laryngologist?
Yeah, I would say, I naturally am more suspicious of it, I would say, than probably the average ENT. And so I may ask a little bit more about progressive dyspnea, progressive inability to tolerate exercise. I would say the biggest thing about this condition is it tends to move along pretty slowly. Classic timeline is about 2 years from when somebody starts to have symptoms to when they actually are seeing a laryngologist. And usually by then their airway is probably 60 or 70% narrowed. And so the biggest thing for me is that kind of slowly progressive loss of exercise capacity, because people will describe this, say, yeah, initially I just couldn't, I used to be able to walk a few miles, then I couldn't walk more than a couple miles. And then now I'm struggling to get up the stairs, sort of having to stop and take breaths as they're talking. And so definitely, the people who are presenting in that way, you'll have that kind of clinical suspicion as you hear them talk as well.
In an adult, do they have sleep disordered breathing or sleep apnea type symptoms as well with this diagnosis?
Not typically, unless they just otherwise have that as a comorbid condition.
And with the mucus, is it mostly just like I've got that postnasal drip or I've got this mucus in my throat that I'm clearing all the time or?
Yeah, usually the latter. So they're going to feel that kind of just feel like mucus is caught. And really what's happening is that the normal ciliary mechanism is kind of catching on that shell. And there's probably increased inflammation in that area. So they're getting kind of a double whammy of mucus that's holding up naturally and then having to deal with this kind of extra inflammatory input. So they're just kind of feeling like I'm always coughing up mucus, and they'll often say they can't cough it out, which is, I would say that's a little different than the average mucus complaint in adults. It tends to be more, oh, I've got this postnasal drip and I'm clearing my throat or things like that. That really kind of, I have this mucus and I can't cough it out is relatively unique to this population, I'd say.
And so for the patient that's, not diagnosed, but they've been dealing with more mucus, increased exercise tolerance. Now it's been going on for about a year. They've seen asthma, they've seen allergy, and they end up in your clinic, but not diagnosed as of yet. What's kind of on the differential? Like with these symptoms, what else is on your differential usually?
Yeah, so definitely thinking about a number of different things, like just kind of the classic globus LPR type profile. I tend to be on the more conservative side in terms of blaming everything on reflux. I tend to try and avoid that. I try and look for other explanations first. But definitely that is a potential to create similar symptoms. Paradoxical vocal fold motion is a big overlap here that not infrequently I do get patients have been temporarily diagnosed with that as well, particularly because they may have PFTs that would show some blunting of the inspiratory flow loop, but not quite the sort of hamburger type flow loop that you see when somebody is really, really narrowed. So kind of in the early part of the disease. Paradoxical vocal motion is definitely something that can overlap symptomatically here, and you'll see kind of that inspiratory difficulty, maybe occasionally stridor, but that tends to obviously be more episodic. And then, of course, there's what I might call like a functional dyspnea, which is just that obviously at times I've had patients who their exercise tolerance is just decreasing, and it's sort of this cycle where they're doing less and they've gained some weight and they just can't breathe as well and can't do as much as they used to. So I'd say occasionally I am kind of saying, oh, maybe this patient could have a stenosis, and we'll do a full airway exam and find that no, the airway is patent. It's just more that they've deconditioned, unfortunately.
And so moving on to your physical exam in clinic, can you kind of walk us through that?
Yeah. So obviously starting out with just kind of a routine head neck exam. I feel like I'm answering the boards, but routine head neck exam. Obviously, there's always this, we didn't get too much into autoimmune disease yet, but that's always kind of the overlap there is the potential for autoimmune disease. And so kind of looking to see, is there a septal perforation, major crusting in the nose, any kind of fluid in the ears, things that make you think of GPA, granulomatosis polyangiitis, the former Wegener's, and sarcoidosis, a couple other, those can be kind of the big ones. And then listening to the patient breathe, having them do forced inspiration, sort of a rapid through the mouth inspiration can definitely help you to kind of hear whether or not there's that coarse stridor. And then moving on to some combination of laryngoscopy or an office bronchoscopy. And if I know coming in that somebody has stenosis on a CT, we're going to be set up already to plan a bronchoscopy in the clinic. And usually I'm just using a channeled scope where we're going to really spray their nose well, get them a little bit set up. And particularly if they have a small nose, we'll pack the nose just because the camera is a little bigger. And then we will go ahead and dribble some lidocaine onto the vocal folds with sustained ephonation. And then that allows me to do a full airway exam down into the trachea and even see the mainstem bronchi. In the patient where I don't know yet, that say they just get sent to me for kind of a non-specific complaint, but I'm suspecting that, and say I'm not set up with a channeled scope and for whatever reason don't have the ability to switch over to that, sometimes we'll just use transcutaneous transcricothyroid injection of 2% lidocaine. So just kind of prep them, tell them that I'm suspicious of something deeper in the airway and that it'll feel a little uncomfortable at first, a little injection of lidocaine and make them cough quite a bit at first to get the lidocaine all through the airway. But most patients actually tolerate that really well in terms of numbing the airway, and then you're able to do a full airway exam with that as well to see the subglottis and the distal trachea, even with a normal or just a regular flexible laryngoscope.
And can we back up just a little bit? When you pack the nose, what's on your pledgets when you're packing the nose, and how long do you let it sit there before you do your bronch?
Usually it's 4% lidocaine and a decongestant. I think we have phenylephrine in my clinic. I used Afrin previously. Usually we're leaving that for a few minutes. I skipped over occasionally. Some patients, particularly patients that are kind of repeat patients, will do a nebulizer as well, or if we have a chance to plan that. But I found the nebulizers to be kind of variable. Some patients really like them. Some patients hate it. Some patients feel so numb and gross, and it just kind of throws off the whole exam. So I actually don't really start with a nebulizer, but that's definitely can be part of the numbing routine as well.
Yeah, I agree. There's that phenomenon when everything is super numb and then they just start, like throat clearing and, there's a little bit of panic and they're not feeling, it's, I think that's really challenging finding the sweet spot.
Well, and everybody's different. I have patients who love the nebulizer. I have patients who hate the nebulizer. I have patients who feel neutrally about it. It's just like everyone kind of needs their own secret sauce on numbing.
And when you're dripping lidocaine through your channeled scope, is that 4% as well?
Yeah, it's 4%.
Okay.
There's an argument you could use 2% as well, but that's typically what I'm using is 4%.
And then when you do your injection, say that one more time. What are you injecting and where are you injecting?
Usually that's 2% lidocaine. It's 2 or 3 milliliters. I'll use a 25 gauge needle and just inject the skin a little bit in front of the cricothyroid membrane and then pop through, aspirate some air to prove that I'm there, and then push through as much as I can before the coughing kind of kicks out the needle.
Yeah.
So hopefully getting 1 or 2 cc's in there pretty quickly.
How long do they cough after that?
It varies. Usually not more than I would say 10 seconds or 15 seconds. Most patients tolerate that really well. Occasionally the supraglottis doesn't quite get numb enough there. And so you have the option of doing an extra kind of transthyrohyalate injection of 2% lidocaine as well. I've used that once or twice if they don't get quite numb enough with that first injection. So, and that just kind of gets the distal superior laryngeal nerve fibers, like if you were doing an augmentation or some Botox injections through that technique.
And then on the scope exam, when a patient does have idiopathic subglottic stenosis, what are you looking for? What does it look like? And how does it look different than the patient who has had an intubation history or a reason for subglottic stenosis?
Oftentimes, this idiopathic subglottic stenosis has a fairly trademark look, I would say, and it tends to be this kind of almost spiral pattern to it. The red, usually kind of slightly red tissue that's kind of spiral, and it may be eccentric, it may be concentric, like you may have a pretty midline circle, but it may be that the left side is pretty involved, but the right side is less so. And so the main differences I would say that I feel like I see with idiopathic versus, say, an iatrogenic, which fortunately in my practice, iatrogenic subglottic stenosis is quite rare. That tends to be a thicker appearing scar, usually doesn't kind of have this spiral pattern to it. It's just usually concentric, sort of thick. It looks more dense and may or may not be located kind of right in this cricotracheal junction area, but obviously can vary a little bit more. Of course, you have the huge history piece of I was in the ICU for the last 6 weeks from those patients as well. And then, the other one that I would say I could be a little harder to differentiate is the autoimmune disease. And so I would say the patients I've seen who present with GPA that's otherwise been diagnosed, which is going to be by far the most likely thing to present in the subglottis, those patients, it looks horrible. It is extremely red. Usually there's a lot of crusting. Oftentimes the vocal folds will be inflamed, and it just looks way more inflamed than I would say the average idiopathic patient looks. They may have a little bit of kind of crusting, but usually it's dramatically more inflamed in somebody who's presenting, particularly with a new diagnosis of GPA, and even some of these other autoimmune conditions that may affect the area. Like, I've seen lupus affect the subglottis as well, and just tends to really show up with a more significant inflammatory appearance.
So once you've kind of spotted that, what happens next?
Usually, ideally we have a really good exam in clinic that we've evaluated the extent of the trachea to make sure this is really isolated to this area, which again tends to be the cricotracheal junction. Then we are going over just the nature of, okay, you have airway stenosis. So that's a huge change for somebody, of course, who's coming in largely healthy, thinking that maybe they know something's wrong, but they're trying to figure out what it is. And so that's a big deal. And kind of just processing that initially with folks is always kind of a first step. And then, we start talking about what to do next. And so I don't necessarily feel like a CT is needed, even though, sometimes patients come to me with one. As long as we have a really good exam in the clinic, I don't think a CT is going to add anything unless I'm concerned for something else going on or structural abnormality or something like that, which A-frame stenosis or something like that tends to be pretty obvious inside the airway as well. And then, in terms of workup, historically, previously I used to get more labs. And I think generally the consensus is that we don't need a ton of lab work to rule out autoimmune disease, in part because many of the labs are so non-specific. So kind of for me now, it's primarily a C-ANCA, and then that'll auto spin off into the MPO and PR3, I believe, are the two kind of subtests for GPA. I order that for everybody. To date, in somebody where I did not have suspicion for GPA, I've never seen that be positive, but there's always theoretically that possibility. I don't get ANA and things like that just because, it's not infrequent they're positive, but you send them to rheumatology or communicate with the rheumatologist and they say, what do you do with that? So I generally don't, unless I am really suspicious that this is something different.
Yeah, I've had that experience too. That positive ANA it's really common. And then you're just like, what does it mean? And then the rheumatologist like, why?
Nothing.
It's not a big deal. Why are you sending this patient? Yeah.
Exactly.
So, okay, cool. So limited imaging, limited labs, because you can, the exam is the big part, right? Being able to see it. Do you ever have to take anybody to the OR to be able to see the subglottis? Maybe rarely.
I don't think I've had anybody, in practice that I've had to do that. Usually we can, even if they're really kind of not going down below the vocal cords, we can kind of adjust their position enough that we can get at least some image of the subglottis. I think there's one patient I did do a CT just because I didn't have a perfect exam. She was pretty resistant to doing some of these more advanced numbing. And it wasn't a totally clear history. So I said, all right, let's get a CT scan. And sure enough, then, she had some narrowing below in the subglottis, and she ended up doing really well with some treatment. So.
Because otherwise, these patients, when they come to you in clinic, they're sleeping flat at home. It's more exertion induced. So getting a CT for somebody that maybe you didn't get a great exam on or that is really tight should be reasonable, right? Because it's pretty quick. And again, they should be able to lay flat for this.
Exactly.
Do you ever have that? Does that come up ever?
I don't think I've run into trouble there. In general, like you pointed out, this is gradual. These patients are very rarely in extremis. And the most extreme part of it is that they feel like nobody's listening to them. And then once they feel like somebody's listening to them, usually they're kind of like, okay, well, I can get around the house and things like that. But obviously they can't do a whole lot. So, I've seen people who really were fighting through their stenosis and come in with airways narrowed to, 3 millimeters, that they were just going because they were convinced that they'd gotten out of shape and just keep pushing it. But yeah, they can usually lie flat for CT or lie flat at home, at least temporarily.
What percentage of your patients, or do you think you've seen where they're on like a bunch of asthma medications by the time? I feel like asthma, at least with pediatric ENT, when it comes to airway foreign bodies, anything like that, that's the great diagnosis that kind of blankets and masks everything until here we are 6 months later and, we have a pneumonia, et cetera, other complications.
Absolutely. Yeah. Usually almost everybody's been through asthma medicines. Usually they say, I stopped because they were not helping. But yeah, usually they'll get a couple different asthma medicines, but then they'll get PFTs and the asthma specialist says, this isn't asthma. You don't have any lung restriction, And if it's early enough in the course, they won't see any sort of upper airway restriction. And so then again, they kind of feel like they're being gaslit, told nothing's wrong. And sure enough, there is something this whole time.
Do you typically see them have exacerbations of their symptoms when they have a cold? Like if they have an upper respiratory infection or COVID or, something like that?
It can definitely happen, although I feel like it happens a little less than I would have expected, just in my kind of experience. I had one patient who really did, she probably had 40% stenosis, had kind of gradual symptoms, and she ended up presenting because she had a really bad exacerbation. And so she was lucky in that we kind of caught it earlier than average, I would say. But most patients don't get huge exacerbations unless they are really tight. If they're at kind of 70% narrowing, then yeah, a cold can tip them over the edge a little bit, or, really cold air and they start to get some crusting, things like that. So it definitely, you can get that kind of additional symptom on top, but I don't find it to happen too much, fortunately.
For these patients, is there medical management? I think of like reflux management, but are we throwing PPIs at these patients? What are we doing?
So, if you look at some of the papers from the early 2000s, I mean, that was the number one theory. And that was kind of common across, I think, ENT and laryngology was this idea that reflux was everything. And there could be some impact, but I tell you, I've had a lot of patients come in and they're on high dose PPIs and they tell me it makes zero difference. So reflux could be playing a role in the very initial onset of the condition, but it doesn't have a clear role in the ongoing symptom management. The biggest thing in terms of medical management, a few different things have been tried. I haven't seen a big trial of methotrexate, but I've heard that being tried occasionally, particularly if there's a thought that there's something else going on, or, just because that is kind of this general immune management. Certainly people will give these patients oral steroids, big doses of oral steroids. And the patients I've seen who've been on oral steroids, unless they're in kind of that acute, I had a cold and I had acute inflammation, don't seem to get any benefit from oral steroids in my experience. I've seen them used as a quote unquote temporizer, as you're getting somebody to the OR. And I don't think patients seem to feel anything with that other than they just kind of maybe feel a little euphoric on the steroids. And then the other part of medical management gets into the Mayo Clinic's kind of triple therapy approach after they do endoscopic treatment. So it may be something we can get into a little better later once we've talked about some of the other interventions, but they kind of do this post-intervention medication strategy.
So what's your decision cutoff? Like, what's going to push you to recommend an intervention versus, you know what, you have a little stenosis, you're doing okay? Because there's such a variable degree of symptoms, it seems like.
Exactly. So most patients, by the time they get to me, they are pretty symptomatic. So that's a big part of it. And that's a difference, again, between some of the iatrogenic type stenoses and things like that, because those can just kind of settle at 20%, 30% sometimes. And those patients aren't that bothered by it. But, a lot of times, by the time I'm seeing an idiopathic patient, they're quite symptomatic. Again, not in extremis, but quite symptomatic. And so my general algorithm is to everybody I meet, I start to talk through all the options. So the standby operation for this, to treat this for the last 30 or 40 years, this condition was first described in the 70s, but I think really in the early 2000s is kind of when it's really been clearly recognized for what it is. To start by just saying, well, the standard is operative endoscopic dilation. And when you look at data, that probably lasts 1 to 2 years for most patients to keep them pretty open. And then they're coming back and wanting another dilation. And so I often will kind of start there. Usually you're going to do a steroid injection there, and everybody's technique is different. Some people use lasers to make radial cuts. Some people use cold instruments. Some people use cryo. There's all kinds of things out there that people use to make the cuts. And I'm of the opinion that there's probably not huge variation between those. So we kind of start there and say, that's pretty standard. I think that many people would offer that. Then, we talk about what's the most definitive option. And I think the data support the idea that the most definitive option is cricotracheal resection, which is when patients who, again, coming in with this background of being pretty healthy and things like that, you start talking about major airway surgery, they're not quite ready to go for it. But we talk through the pros and cons of that. The best data suggests that it's quite durable. There's some anecdotal reports that maybe 8, 10, 12 years down the road, it can come back, but that hasn't really been published. So that's something that's still kind of out there in the ether, is a little uncertain. But, it's quite durable. And the big drawback is that usually the pitch of the voice lowers because of detaching the cricothyroid muscles. And there's some variations out there that have been proposed, but generally it's still seen as pretty likely to lead to a lower pitched voice, which for a woman in her 30s or 40s is a quite undesirable outcome. And so that's a big part of that consideration. And then I talk about the third part of the management that I often will share with patients, which is steroid injections in the office, being called different things, but I think we've kind of all come down to this SILC, serial intralesional steroid injections, is kind of the easiest way to describe it for the literature and for patients. And those can be delivered quite easily, again, with some of the similar techniques we were talking about in terms of numbing the airway and then either injecting through a working channel scope or through transcutaneously. And so I'll kind of bring up these three options, and then with a couple caveats in there, there's some variations of endoscopic procedures like laser excision and a Mattern procedure that's out there as well. We can get into those a little more, but basically kind of get these three kind of broad approaches to management that I'll start with, and then start to kind of discuss with the patient where their priorities are and what they feel like is better for them to start out with.
And so for your patient who's not ready for a procedure, it sounds like most of your patients are at that point, but let's just say there's somebody who's like, whoa, I just want to kind of wait and watch. What's the natural progression of this? Do most people tend to have a progressive course in idiopathic subglottic stenosis to where you would expect that eventually they're going to come back and need something? Or do some people kind of stabilize at a certain stenosis that can be tolerable?
That's a great question. I think we still don't have that answer exactly. I've not had a patient elect observation.
Right. Yeah. You're,
and that's across kind of training and practice. I don't think I've seen someone elect to do nothing. The general sense is this will progress. There probably is some point at which it may stop for many patients. There are rare reports of patients with this condition dying from acute plugging events. So it's certainly not completely, there's not a guarantee that it's going to stop in a way that would be non-fatal. But I would bet that for many patients, it may get to a 4 millimeter airway, and then kind of just by the nature of air passing through, it may stop. But I can't say for sure. And so I generally advocate doing something. And most patients, I've never had a patient where I had to convince them to do something.
Right. They're coming to you for a solution.
Exactly.
So your three options are steroid injections, a dilation, or a cricotracheal resection. Those are the three big categories.
Those are the three big categories, exactly. And so within the kind of dilation discussion, I'm usually offering an endoscopic laser resection of tissue plus or minus dilation is where I've settled. And that's kind of based on some data that's been produced, particularly out in Mayo, as well as the North American Airway Collaborative comparative outcomes. So I generally am offering a laser resection if we're doing an endoscopic operation with steroid injection. But if somebody's the occasional patient I get who's only at 40 or 50% stenosis, or even slightly less if we're really lucky, I will offer them to start with steroid injection in the office with a biopsy done in the office, just again to kind of rule out autoimmune disease. Everybody gets a biopsy, in my opinion, just to make sure. I've had one and maybe two patients kind of where we started with that approach and were able to avoid the OR altogether. And, she had a really good response to that.
That's interesting that steroid injections are helpful, but oral steroids aren't helpful at all. Why do you suppose you just think the concentration that you're able to deliver with an injection is just so much higher? Or any thoughts on that? Because we love giving steroids as ENT.
We love it.
To hear that steroids don't work is like, what?
It's a really interesting question. And there's definitely debate within our field. I would say most laryngologists I know are using these, but there's a few with very prominent laryngologists that are pretty skeptical. And there's a couple factors. So, one of which is what's the underlying problem? What's going on here? And Dr. Gelbart at Vanderbilt has kind of led a lot of the high level basic science research into this. And I don't want to ignore his colleagues there, but he's kind of the person who's, I think, spearheading it right now. He's shown that there is this kind of lack of epithelial integrity, some invasion by bacteria. There's a little bit of a chicken or the egg question, kind of what starts the process, we're observing the process after it started. So what's going on there? But ultimately you end up with this inappropriate fibroblast process as well that's laying down scar where you shouldn't be laying down scar, and sort of an alteration of the immune response in the subepithelial tissue. And so the steroid injection side, how that addresses it, the theory, from what I understand, came from what we see in keloids and hypertrophic scar and kind of approaching those. And Dr. Franco and Dr. Daly have both been big early adopters. Well, Dr. Franco was the first person to describe it, and then Dr. Daly also has been an early adopter of the steroid injections in the office and seen really good results with these since about 2014 or so. And Dr. Franco recently presented, I believe it was a poster actually, but some basic science showing that the fibroblast activity actually has changed with steroid injection. And I don't think we get that from oral steroids, or at least we can't give oral steroids long enough to achieve that response. But basically, a fibroblast activity is changing from laying down scar to actually removing scar. And that's hugely valuable, of course, when we're talking about really just needing a few millimeters of airway and needing some improvement in that scar deposition.
And for your steroid injections, whether you decide to do initial treatment of the serial injections or at the time of your endoscopic dilation in the OR, what steroid do you use and how much do you end up giving? Do you have a special needle you like?
Yeah, so I'm using Kinalog 40. I think that's pretty standard across the field. We like that kind of deposition. And of course, that's what I think a lot of facial plastic surgeons and folks have used in keloid as well. But I use that just with there's an Integra laryngeal injector in the OR. So usually I'm removing the tissue and then injecting steroid and then possibly dilating a little bit after that just to make sure the airway is completely open for somebody coming out of anesthesia. And then in the clinic, I'm using either a 25 gauge needle trans cricothyroid with a physician assistant driving a camera, or I'm driving a working channel scope with a sclerotherapy needle through the channel. That is, I believe, a 2023 gauge that we're getting into the tissue kind of subepithelially and infiltrating with the Kinalog.
And you just kind of try to do several little injections around the edges of it.
Exactly. Yeah. Just finding places where there is more scar deposition, where there's more tissue and filling that tissue. So I generally aim to do about 1 milliliter plus or minus. It just kind of depends. Patients who have minimal stenosis were oftentimes doing less than that. And then usually it's done in a series. So if somebody's starting out with treatment that way, we're doing it in a series of 3 or 4 injections over the course of 3 or 4 months. And oftentimes after somebody is taken to the OR, I offer a series of injections afterward as well. There's evidence that helps to improve the intraoperative interval. And for some patients, it really keeps them out of the OR entirely. We had a good number of patients at University of Wisconsin who stopped going to the OR with this approach. And I've had that experience as well, taking over practice from a surgeon who is treating patients with dilation every 6 to 12 months or so based on their symptoms. And a number of them have switched to steroid injections. And it's been 3+ years that I've been here and they've never had to go back to the OR. So some patients respond to it beautifully. Not everybody does. We still don't quite have a handle on why those patients who don't respond to it really well don't. But certainly there's some variability in that.
And it's every once a month for 3 to 4 months?
Correct. And then after that, and this is where I think there's a lot of variation. I think a lot of laryngologists are using that approach, kind of if somebody elects endoscopic treatment and kind of doing this post-operatively. But I think there is quite a bit of variation around the country in terms of how we approach it after that, whether folks are followed or folks are told just to kind of come back if their symptoms start to worsen again. And there's, I think, a huge variability in terms of how that practice is approached.
Meaning come back, we'll be scoping you every 3 to 6 months until we need to intervene versus just come back and see me if you're getting the mucus and having more dyspnea and exertion and your original symptoms that you had.
Exactly. There are a lot of different approaches, as I've said. So some folks will use PFTs. Some people will use a peak flow meter. I like to use a peak flow meter because it's so simple and can kind of approximate for a patient if they see a decline in their peak flow out, that they know that can kind of corroborate their subjective symptoms, and it's cheap. And then classically with the dilation approach, a lot of patients would get a dilation and just kind of be told, okay, if when you start to feel tight again, give me a call. We'll do another dilation. Whereas I tend to offer to patients to come back in and starting out, coming back in a little more frequently, 3 months. And I have some patients who have kind of found that if they come in every 6 months and get a steroid injection, they're pretty good. And they're thrilled because they were getting dilations every 9 to 12 months. And now they're getting a steroid injection every 6 months. And between those injections, they still feel good. Whereas with the dilation, after a couple months, they were just kind of biding time until the next dilation.
Can we talk a little bit more about the dilation technique? So You're doing this in the OR. Is this with general anesthesia using rigid bronchs and suspension, or is the patient still awake? You're doing topical, flexible scopes. Like, how do you do it?
So my approach is to do this under general anesthesia with paralysis, with rocuronium paralysis on board as well. But we do this kind of graduated approach. So, I've got a team there that's gotten really comfortable with these cases as well. So we have a great team set up, and we start with induction, just using propofol, getting the patient quite deep, ensuring that they can be masked safely. So we always have that ability to back out. And then we're giving rocuronium paralysis to allow for rigid instrumentation. And then I go in with a DITO typically, or sometimes a smaller laryngoscope, depending on the patient, and start supraglottic jet ventilation. So just running a jet through the side port of my DITO. And from there, we actually use an oxygen mixture. So we can usually ventilate with jet at 30% while removing tissue with the laser. So we don't actually have intermittent apnea. But sometimes patients don't tolerate that as well, particularly patients who are more obese, for example. So we will either do intermittent apnea with ventilation at 100%, or just open the tissue some with a laser and or a balloon dilation, and then intermittently intubate with a 5.0 tube through the laryngoscope.
And what laser do you like to use?
I use a CO2 laser with an AccuBlade pattern generator, typically a line for that. And using the ultrapulse mode, there is some evidence that the continuous mode laser does have a higher risk of edema and tissue injury that could create a postoperative issue. So fortunately with the ultrapulse, I've not encountered that.
And rather than just doing radial incisions, you're actually removing the scar as much as possible.
Yeah, exactly. So it's, again, a protocol that has been described at the Mayo Clinic. A number of surgeons there have been using it for years now, where they essentially use a radial cut to identify the depth of the scar, and then using the laser to remove that scar tissue as much as possible in this wedge fashion. So usually leaving a small wedge of tissue in between, usually 3 or 4 kind of tiny little bridges in between, with the idea that a complete circumferential excision would create risk of encouraging scar formation.
Gotcha. And then after you've kind of removed these small segments, then you inject those areas with your steroid.
Exactly. And so, when you're doing the laser excision, I don't know how much the steroid does at that time. I think it's more beneficial in the postoperative setting. But typically I'll inject steroid at that point. And if I feel like, it's still kind of creating a little bit of a bleb in the tissue, or that the patient might feel restricted at all coming out of surgery, then I'll do a balloon dilation. Or for some reason, I'm just finding that I'm just not able to get as much tissue out as I'd like to.
And then in the OR, what red flags should we keep in mind for an airway emergency? Or, do you always have a trach tray available? Or, hey, you said, hey, we mask him down because if we can't mask him, we at least have the opportunity to back out. Can you tell us a little bit more about some of those things that we should be thinking about?
Yeah, absolutely. So I always have a trach tray in the room. I don't typically have it open unless I have a particular concern about a patient. Obviously, we have the preoperative exam to have a sense of how narrow the patient is, and then considering other anatomic features in terms of their ability to be masked. If somebody has significant adiposity, cervical adiposity, or large tongue, OSA type features. Knock on wood, I've not actually encountered the patient that I can't mask, which is really good. In fact, it's realistically, the vast majority of these patients are going to be able to be masked unless they're really, 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 really narrow or crusting in some way. There is kind of the option of salvaging with an LMA. For some reason, sort of oral or oropharyngeal structures are giving you trouble with the mask. So you can put in an LMA. If you have trouble with rigid exposure, that's really kind of, I think, the big next branch point. There's going to be the occasional patient that just cannot be exposed with rigid exposure with any laryngoscope. I've run into that once over my career. And that patient can often be treated, though, with a LMA and then using a flexible scope. You can use a laser fiber, but at least can get a balloon dilation done that way, and steroid injection. And that's really how our pulmonology, interventional pulmonary colleagues treat most patients as well, of course. I mean, they'll do some rigid bronchoscopy, but that's kind of the bread and butter for most interventional pulmonology treatments. So that's a very viable option. I always talk through with my anesthesia team what our plan A is, and then plan B, plan C, and then, plan D or E is always, tracheostomy, but we try and avoid that.
What about post-procedure instructions?
You had mentioned the Mayo post-op protocol.
Yeah, so they've done this so-called triple therapy, which is Bactrim, proton pump inhibitor, and steroid inhaler. And I offer that to every patient that I treat. And I haven't had anyone take me up on it, at least all three. And a lot of it's probably how you couch it or how you sell it. For me, I probably don't push it really hard. I saw a presentation from the Mayo team that showed that probably the Bactrim is the most influential. And as I understand, they backed off prescribing proton pump inhibitors if patients don't have overt reflux or pH study proven reflux. So the Bactrim is probably the most impactful, which makes sense with what we've seen in terms of kind of translocation of bacteria. And that was based on, I believe, some patients with GPA responding well to Bactrim. In Western Washington, there is not enthusiasm for long-term antibiotics. It's culturally, there's a lot of enthusiasm for alternative medicine out here, but not a ton of enthusiasm for big doses of pharmaceuticals. So I think been driven a part of it. I've had a couple patients elect Bactrim, but not frequently. But again, I'm not telling them that this is the way to go and this is the absolute only options. There's always that element of it, and you can get into that in terms of which patients are electing cricotracheal resection or these different options too. A lot of it is how it's couched by the surgeon, probably, and our biases one way or the other in terms of what we think is kind of the better option.
Is that protocol just for patients who are having like a dilation or an excision of the scar, or does that apply to the intralesional steroid injections, or not really?
In theory, it could apply to either. It's been called endoscopic resection with medical therapy, I think, ERMT or EMRT. I hope I don't upset anybody over there if I'm missing some of the details here of their protocol, but they had designed it where they do an endoscopic resection and then put patients on medical therapy. And there is some evidence that people get longer intraoperative intervals that way for sure, by a reasonable margin, particularly compared to dilation alone.
How long are they on those medications?
To my understanding, indefinitely. And so, okay. Again, that's where I don't have a lot of patients who are ready to sign up for that.
Yeah, I could see how that would be a hard sell. Any other post-procedure instructions that are important for you in particular? Or are there any supplements that your patients take that are found to be helpful?
So number one is the kind of acute post-procedure. What are the things that could be really bad? So when you're doing jet ventilation, there's a theoretical risk of pneumothorax. That's been described, in the literature, and certainly I've heard of it happening. So if somebody has, I don't check an x-ray after every case. Personally, I know there are some surgeons who do. My experience has been that it's very, very, very rare for that to happen. And fortunately, in my practice, I haven't observed it. But encouraging people, if they have dyspnea, if they're feeling really short of breath, that's a red flag. If they're in PACU and they're feeling short of breath, that's a problem. They should be breathing a lot better than they were. So, I check on patients, make sure that they are breathing better, meaningfully better than they were. And if they're not, then we need to evaluate that. The other thing would be kind of subglottic or laryngeal edema. And again, you'd be hearing, they might come out of the OR with nothing. And then if the PACU says, hey, they're starting to get more stridor, they're starting to sound worse, that's a big red flag. And you need to be evaluating that and looking for swelling. the vocal folds are probably the bigger risk in that situation, that you get glottic edema. In rare scenarios, that would mean, reintubation or ICU monitoring and ideally avoiding a tracheostomy if at all possible. But that's always your final pathway. So those are the big things in the acute, immediate, postoperative. Some surgeons will give patients prednisone bursts. If I feel like there's a little bit of laryngeal edema, but nothing significant, I may give somebody a short prednisone taper, because that's certainly laryngeal edema responds to prednisone, no question. And then otherwise, talking to folks about management of that mucus sensation, usually Mucinex and acetylcysteine. So a couple of patients have actually elected a saline nebulizer, nebulized saline that kind of helps to clear out that mucus and thin out the mucus. Personal steamers, kind of all these different mucus options can definitely help with some of the symptom management. And then, like I said, I'm following the patients pretty closely. So usually I'm meeting them again within a month from surgery. Most patients elect to at least try steroid injections. So most of the time, if we're doing an endoscopic procedure, I'm meeting the patients about a month after surgery.
And for these patients, whether at initial presentation or post-op, voice and swallowing is usually fine. This is more of a breathing issue, yes?
Exactly. some patients will have some involvement of the infraglottic vocal folds. And so some patients do experience this as hoarseness, worsening symptoms, but swallowing would be very rare to have any issues there. And the vast majority of the time, it's going to be a breathing issue.
And just transitioning to CTR and open airway, are there certain hard indications for CTR? Is there a certain amount of stenosis, or hey, now we're in the OR every 2 to 3 months? When do you start to that, hey, we're here now?
Yeah, that's really driven by the patient scenario. I think some patients are very interested in that upfront. I would say it's a minority, but some are. And then I don't know that there is necessarily a cutoff, but certainly if patients are just needing constant, really frequent interventions, then you're really thinking about some of these more aggressive surgical options, whether that's a CTR or this kind of what you might call an endoscopic CTR, which is the Mattern procedure that's mainly been developed at Cleveland Clinic, where going in with a microdebrider actually and removing the scar with microdebrider and then putting in a stent with a graft, either split thickness skin or buccal mucosa, to try and reline that tissue. So it's sort of a middle ground between the options, so to speak. And they just published a series of almost 30 patients or so that have had pretty good results on average. So that's definitely something that's out there as a potential kind of middle ground between cricotracheal resection and the associated risks and potential issues there and the endoscopic options.
And do you ever have patients where tracheostomy is the best option? Like, who are those patients?
Occasionally, there are patients who are just fed up with it, are either considered too high risk. Diabetes is always considered a big risk factor for cricotracheal resection. And I've, not in my current practice, but I have seen patients who either had kind of a mucus plugging event and presented emergently and gotten a tracheostomy, or, were in a place where there wasn't somebody who could do jet ventilation and things like that. And just found that once they got used to a tracheostomy, they said, oh, this is actually easier than going back to the OR and things like that. And actually found it to be pretty manageable. So I have seen a couple of patients who actually, ultimately prefer, or at least have elected just to use a tracheostomy and kind of bypass the issue.
Sounds like that's the minority, though.
Correct. Yeah, absolutely.
When you kind of think about your patient population, specifically for the idiopathic folks, what's more common as far as procedure-wise? Do you feel like excising the scar and doing the dilation is the most common road? I feel like just from an outside kind of looking in, that seems to be less invasive than, the cricotracheal resection, but also kind of more aggressive than just an injection. I don't know. But what do you think?
Yeah, that's been my experience. I inherited some patients who have been previously treated with dilation alone. And then if we've needed to go back to the OR, they've been interested in adding the laser resection. And then again, surgeon biases play a role here. I hope for the better, not for worse, but surgeon biases certainly can impact how patients, what they elect. But many of my patients have elected steroid injections in the office as an adjunct to endoscopic procedures. And, many of them have been really, really happy with the change in experience. I mean, all the patients that have continued to elect them certainly have, with the change in experience from this kind of gradual decline that they experience going into repeat dilation versus, being able to stay open. And even when those patients that are on that are getting steroid injections, even when they do say, I feel like it's tight enough that I just want to go to the OR, they're going to the OR at 40%, 50%. They're not going to the OR at 75 or 80% where they're kind of, barely making it in. So that's been a big impact in the positive for most of the patients I treat.
And do insurance coverage questions kind of come into it? Like, are patients pretty much free to select whatever pathway works best for them? Or sometimes is there a discussion of coverage that has to come into play that also, dictates what happens next?
That's a great question. And for me, in the environment I'm in, it doesn't come up as much since I'm in an HMO capitated model. That's a big question for patients who are, say, on a high deductible plan. I would think in that, if they're doing steroid injections frequently on a high deductible plan, they're probably going to hit their high deductible every year. And that's going to be really cost intensive. I mean, we see the same thing for Botox injections and things like that too, that one of these injections could bill at a couple $1,000s to somebody on a high deductible. So that will definitely impact their decision making. I'm not aware of insurance really blocking these, but again, I'm kind of fortunate in that I'm in a model where we don't have as much of that back and forth. I certainly see our message boards and know that that's not always the case. So I feel fortunate in that regard.
But when you think about the procedures, there's probably different costs when you think about, going straight to a CTR, which is probably more expensive up front, but maybe less expensive over time versus needing to have serial dilations versus serial injections. So in a HMO capitated model, eventually there may be pressure to, steer patients towards a more cost-effective option. I don't know. I'm just talking out loud.
I think that's a great question. Kaiser Washington is relatively small compared to like Kaiser Northern California and Southern California. And I talk with those laryngologists. They certainly have not been pressured one way or the other. I talk with them a bit, and a lot of them are using steroid injections and some combination of endoscopic management, occasional CTRs. So that's a really interesting kind of big picture question when you get into particularly kind of managed care and optimization of, health outcomes versus cost of the system. But fortunately, at some level, this is such a rare condition and if you're talking health system wide, drop in the bucket.
Yeah. It's a small patient population. Yeah.
Well, as we start to wrap things up, Steve, any final pearls that you want to leave our listeners with or thoughts on the topic?
Yeah, I would say the biggest thing is just to have that suspicion. And it's the same thing across all these different more rare conditions is just have the suspicion that, there could be something more to it. Not every globus, not every mucus sensation is reflux. Not every person with some dyspnea is paradoxical vocal full motion. That there's always this kind of, just to have that suspicion that these are rare conditions, but certainly at least be aware that there's a possibility and be ready to look a little further if you need to. I had a colleague I was talking to and I was saying, gosh, I just wish people would just inject lidocaine into the airway more often. And he was like, what are you talking about? Like, that's not, that's not normal. And I said, well, but there are times where just getting the airway a little more numb and actually taking a really good look can diagnose something that can really help a patient. And again, the earlier we find this, the more options patients have, the more they can be treated effectively and not have to kind of suffer through this horrible progression and feeling like they're not being heard.
Well, thank you so much for coming on, Steve. It was wonderful to have you.
Absolutely. Thank you so much for having me.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ENT on Instagram, LinkedIn, or Twitter. BackTable ENT is hosted by Gopi Shah
and Ashley Agan.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter, Aaron Bowles, Nick Shellcross,
Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon Hess.
Social media and PR by Chi Ding.
Administrative support provided by Jamila Kennebrew.
Thanks again for listening and see you next week.